Assalamu alaikum everyone. Hope you're all doing good. Today we are going to discuss a very important topic on childhood exanthem. Exanthem is basically a rash. If you see children, it's very common in childhood. There's a rash, a redness appears all of a sudden, sometimes with fever, sometimes without fever. In childhood, we come across these kind of infections. These are very common in our childhood. So we are going to discuss certain conditions where we see these exanthems. Okay, so and these are very common. These are very harmless in nature mostly, and the causes, the primary cause for these exanthems are viruses. Now, these viral exanthems, they may manifest either as macular, maculopapular, papular, urticarial, or vesicular rashes. What are all this? I'm going to show you in next slide with pictures and explain them. Uh, Examples from other causes like bacterial toxins, drugs, and certain diseases, autoimmune diseases, these have to be differentiated from the viral exanthems. They are different. Now, here we can see this is a reddish, flat patch kind of thing on the skin surface. This is called as a macule, whereas papule, the slight elevated lesion. Yeah, you can see here. This is papule, and these are maculopapular rashes. These are reddish and also associated with papular lesions. And here you can see vesicles. Vesicles are nothing but fluid-filled lesions, raised. Now, how will you define an exanthem? It appears suddenly and it affects several areas of the skin simultaneously. And these are mostly infectious in origin. Now, these infectious viral exanthem, they may appear directly as a result of viral infection or indirectly as a result of immune response, which are known as indirect exanthems or para-infectious. Infectious exanthems, the direct classic viral exanthems. Infectious exanthems, these were discovered how they have appeared. According to it, they have been numbered. First is measles, followed by scarlet fever, rubella, erythema infectiosum, exanthema subitum. Now here, there's another exanthem which is identified as fourth disease. It was identified around 19th century, but it was not seen after that again. Okay. Talking about measles, which is also known as rubeola, measles virus basically it is a single-stranded RNA virus, and it is a strictly human virus. It infects humans only. How is it transmitted? It is transmitted by direct contact or via respiratory droplets. Now, sometimes, apart from respiratory droplets, sometimes it can be a airborne infection too. How does it enter? The portal of entry is through the mucous membranes of nose, conjunctiva, and oral pharynx. Initial proliferation occurs in the lymphocytes. We all know what are lymphocytes: T and B cells, monocytes, and dendritic cells. In these cells, the initial proliferation of the virus occurs. And here, what happens? These viruses, every virus and the cells, they have these receptors by which they connect to each other. Now, these cells, they express a particular receptor, cellular receptor for measles virus, which is CD150, SLAM CD150. SLAM stands for signaling lymphocyte activation molecule. These are the important cellular receptors for measles virus. So these cells express these CD150 receptors on them. Now, how does this measles present? They present as first viremia stage, which is around 2 to 4 days, initial 2 to 4 days. After infection, this virus, what it does, it is carried by these lymphocytes, the cells, whichever cells are attacked by these infected lymphocytes, monocytes. These cells carry the virus to the lymphoid organs like thymus, spleen, Peyer's patches, and here, after carrying, they land here, and then the massive proliferation of this virus occurs. That was the first stage where the virus is carried and the proliferation occurs. Now, second viremia is the stage. It starts 7 days after infection. Now here, after proliferation, the virus spreads to skin, mucous membrane, kidneys, lungs, gastrointestinal tract, and liver. This is the second viremia stage, and very important stage. As the virus spreads all over the body, CPE is nothing but the cytopathogenic effect exhibited by the virus. How does it happen? It results from the fusion of virus infected and non-infected cells. All these cells, they combine to form a mesh-like structure. The huge giant cells are formed, multinucleated giant cells. Later on, it definitely gets killed. So this is a typical of viruses, okay, the cytopathogenic effect. Exanthem, what is this rash? Exanthem, what exactly is it? Do you think it is CPE? No, it is not the CPA, but this exanthem rash appears due to the interaction of T cells with virus-infected keratinocytes. When the keratinocytes, skin cells are infected by the viruses, and endothelial cells which are infected by the viruses, the T cells, when they interact with these cells, the exanthem, the rash appears. The disease is contagious 3 to 4 days before the eruption of exanthem and up to after 4 days, like you can say 4 days before and 4 days afterwards, okay, after the eruption of exanthem. Now, what is prodrome stage? It is highly infectious. Now, the incubation period lasts for around 14 days. It's like 7 to 14 days. And this prodrome stage, it starts with triple C and P. You remember this. Triple C stands for cough, coryza, conjunctivitis, and photophobia. After 2 days of prodromal illness, the typical mucous membrane lesions known as Koplik spots. Koplik spots are the white spots. White spots you can see on the mucosa. Buccal mucosa, more commonly it appears on the buccal mucosa, but it can also appear on the conjunctiva and vagina sometimes. Now, these Koplik spots, they might last for a day or two and then they disappear. When you see these Koplik spots along with other clinical signs and symptoms, you can diagnose the infection. Here is a picture. You can see in prodromal stage how it looks like, the conjunctival infection. And these are the Koplik spots, white spots present on the mucosa. Within 12 to 24 hours of the appearance of these Koplik spots, the exanthem of measles, the rash, the characteristic rash of measles, what happens? It starts below the ear and then it spreads all over the body. This typical rash is maculopapular. All right. You want me to repeat? Okay. We were basically talking about the childhood exanthems, isn't it? And childhood exanthem is nothing but exanthem is nothing but a rash, red color rash you can see. So now this exanthem, we were talking about exanthem. It appears suddenly and they affect several areas of the skin simultaneously. In children, these rashes you might have seen maybe in your childhood or the other children. You can see the typical appearance of a rash sometimes with fever or sometimes without fever. So we are going to talk about these rashes. These the most common cause for these rashes are viruses. Apart from viruses, it can be due to some other diseases like autoimmune diseases, bacterial toxins. Okay, so these are direct and indirect viral exanthems. These are also called classic viral exanthems. These infectious exanthems, they were discovered around 800 years ago, and they were numbered in their order of appearance as six diseases of childhood. According to the appearance, whenever the period of appearance of this, they have numbered accordingly. First is measles, followed by scarlet fever, rubella, erythema infectiosum, exanthema subitum. The exanthem identified as fourth disease in the late 19th century. It was identified, but after that it was never seen. It was just identified at that time, and later on it was never seen. So we will talk about measles first. Measles, which is also known as rubeola. Measles virus, it is a single-stranded RNA virus, strictly a human virus. How does this get transmitted? It gets transmitted by direct contact via respiratory droplets, and sometimes it might be airborne, but the commonest route is respiratory droplets. Portal of entry is the mucous membrane of nose, conjunctiva, and oropharynx. Here, what happens after the virus enters through these mucous membrane, the proliferation of the virus occurs in the T and B cells, monocytes, and dendritic cells in the tissues. Okay, uh, these cells they carry a cellular receptor, a specific cellular receptor for measles virus, which is known as SLAM CD150. SLAM stands for signaling lymphocyte activation molecule. Okay, so these cells carry these receptors which are specific for measles virus. Now, after entry, after proliferation, what happens? First viremia stage starts, initial stage, which lasts up to 2 to 4 days. Here, what happens? The virus is carried by the infected cells to primary and secondary lymphoid organs. Okay. Now, after carrying this virus to the lymphoid organs, massive proliferation of the virus occurs. All right. This was the first stage. Coming to the second viremia stage, that is after the 7 days after infection, the virus spreads to skin, mucous membrane, kidney, lungs, gastrointestinal tract, and liver. It spreads all over. Cytopathogenic effect is a specific effect exhibited by the virus. It is very characteristic feature of the viruses. In CPE, cytopathogenic effect, what happens? The fusion of virus infected and non-infected cells. They all fuse, they all club together, okay, to form multinucleated giant cells, and later on these cells get killed. So this is a characteristic feature of virus. Exanthem is not by as a result of CPE. Okay, CPE has nothing to do with exanthem, but the rash appears due to the interaction of T cells, that is CD8 cells, with virus infected keratinocytes and endothelial cells. When these interact, the rash appears. The disease is contagious 3 to 4 days before and 4 days after the exanthem, appearance of the exanthem. And it is highly infectious in the prodrome stage. Now, what is prodrome stage? Initially, what happens after the incubation period, that is around 7 to 14 days is the incubation period, the prodrome phase starts. It starts with high fever, and remember this abbreviation triple CNP, that is cough, coryza, conjunctivitis, and photophobia. Uh, it starts with these symptoms. After 2 days, a typical mucous membrane lesions known as Koplik spots appear. What are Koplik spots? I will show you an image of Koplik spots. These are tiny white spots on the mucous membrane of on the buccal mucosa. It can very commonly appears on buccal mucosa. Apart from that, it can also appear on conjunctiva and vagina. These vesicular lesions, they last for around couple of days, like 2 days. Then you can diagnose the infection with the appearance of these Koplik spots along with other clinical signs. Here is a picture of conjunctival infection in the prodromal stage. These are the Koplik spots, if you can see. White, tiny white spots. Now, after the spots appear, after a couple of days, a typical measles rash appears below the ears. Okay, it starts from below the ears and it spreads over the body. The rash is typically maculopapular, and it takes 1 to 2 days to cover the body, whole body, and later on it fades in the same order how it appeared. If it had started below the ear and then followed by other parts of the body, it will disappear in the same order. And in this phase, patient has high fever and is very sick. This is a typical measles rash, maculopapular in nature. Complications. What are the complications of measles? Here, what happens? Immunosuppression occurs, first of all, during the sickness, and it lasts for around some 4 to 6 weeks. And obviously, when there is immunosuppression, what happens? So many opportunistic bacterial infections occur, like pneumonia, diarrhea, otitis media, or renewed activity of a chronic disease. Like if there was any tuberculosis, then the reactivation occurs. Okay, a particularly feared complication is post-infectious encephalitis, which occurs around 1 in 1000, and it occurs in the end of first week of the exanthem. Uh, this is about post-infectious encephalitis. It is caused by immunopathologic reaction, basically, which is caused due to demyelination of neurons and occurs most often in older children and adults. This complication, the post-infectious encephalitis. Talking about another complication, subacute sclerosing panencephalitis. It is a relatively rare complication, it occurs 7 in every 1 million of patients, so it is very rare. How does it appear? It occurs when a defective measles virus, it persists in the brain, and it acts as a slow virus. Later on it remains latent, and later on it reactivates approximately around after 7 years after clinical measles. How do you diagnose it? Laboratory diagnosis. The clinical manifestations are characteristic. It may not, for these viral infections, always you might not need any lab investigations. Clinical signs, symptoms, history of the patient is enough to diagnose the infection. It is definitely very difficult to isolate and grow. Measles antigen can be detected in pharyngeal cells or urinary sediment by immunofluorescence method. Another method, important methods include RT-PCR, Giemsa stain, and immunoglobulin detection. Giemsa stain, it shows typical CP exhibited by the viruses, cytopathogenic effect exhibited by the viruses. Giemsa stain detects it. And IgM antibody can be found when the rash is present. Infection, it can be confirmed by finding this fourfold increase in the titer of measles specific antibodies. Okay, between acute stage and the convalescent stage. What is convalescent stage? Anyone? Yes, you're right. Talking about treatment and prevention, we all know about MMR vaccine. It is a live attenuated vaccine. Either it is given alone or in combination with mumps and rubella, which is known as MMR. Now, these immunocompromised individuals and also pregnant women and people with allergies to certain components which are present in this vaccine, like gelatin and neomycin, should not receive MMR vaccine. Exposed susceptible people who are immunocompromised should be given immunoglobulin beforehand to reduce the risk of this illness. If they are exposed within 6 days, they need to take this. And in children or teenagers, we must avoid giving aspirin. Why? Because this aspirin has been linked to Reese syndrome. It is a very potentially life-threatening disorder. High dose vitamin A also, according to WHO, it also reduces the risk of measles mortality. No specific antiviral treatment is available, so the treatment is symptomatic. According to symptoms, we give the treatment. Coming to rubella virus, another important virus, the rubella virus infection is global. It is seen everywhere. It is a RNA virus, it is single stranded, positive sense, and it is also strictly human virus. Transmission is by respiratory droplets or by direct contact, and also vertical transmission occurs in rubella. Portal of entry is respiratory tract. Here, what happens after initial proliferation? The mucosa, the virus proliferates and it spreads to the lymph nodes like cervical and occipital lymph nodes. It spreads to it. After a week of infection, the virus, it is detectable in the blood and also in the nasopharyngeal secretions. In this period, the virus spreads to the skin and other organs. Xanthem, I mean rash and arthralgia is an expression of immunological interaction, that is immune complexes. No virus is seen in the skin lesions of this infection. How does it present? The clinical features. After an incubation period of around 2 to 3 weeks, disease it manifests only in 50% of the infected people. You cannot see the clinical manifestations in all the exposed persons. Only half of them they show you the typical clinical manifestation. How the characteristic features are low grade temperature, like low grade fever, headache, which starts at the prodrome and it ends at the end of illness. I mean, throughout the period, the patient has this low grade fever and headache, and also rash, that is maculopapular exanthem. And this rash is craniocaudal in distribution, which disappears in 1 to 3 days. Hallmark of the disease is symmetrical, you will see symmetrical lymphadenopathy, mainly affecting occipital and post-auricular, which are behind the ear, in these lymph nodes. Rubella patients, they are very contagious for 1 week before appearance of the rash and at least a week after appearance. Like a rash is appearing today, has appeared today, 1 week before, 1 week after. Till this, the patient is contagious. Natural infection, it gives lifelong protective immunity, and serum antibody, if they are present in a pregnant woman, then they prevent the spread of virus to the fetus. As I've told you, vertical transmission of this virus is possible. So if the mother is protected, then the fetus is definitely protected. We will talk about congenital rubella syndrome. Rubella, it is a very fatal disease in early gestation. It might, it might even kill the fetus. It leads to fetal death and premature delivery and a lot of congenital defects. The effects of rubella virus on fetus, it depends on the time of infection. As the early the gestation period, it is highly fatal, highly infectious. First 2 months of gestation, 65 to 85% chances of fetus are being infected. Okay, if it is third month, like 12 weeks, then 30 to 35%. And if it is after that, like 16 weeks, then the it is 10%. Sometimes what we see, the fetus, I mean, only deafness we can see with this rubella virus. If it occurs around 20th week of gestation, the baby will have deafness. Then you must think about rubella. Now, this virus has certain complications like embryopathy. If the mother does not have the antibodies in herself, then the virus can replicate in placenta and spread to the fetal blood supply and throughout the fetus. Definitely, if it enters the fetal blood supply, it will enter throughout the fetus and it causes hazardous damage. Rubella can replicate in most of the tissues of the fetus, and it is not cytolytic, but it will alter the many normal things. It will alter like chromosomal structure of the cells, and then it results in proper development of the fetus. It might be small baby infected definitely, and with teratogenic effects. Diagnosis is important in pregnant women, so as we can protect the fetus, and the baby can be protected from this infection. If it is suspected, then in pregnant women, diagnosis should be confirmed by detection of immunoglobulins, that is IgM. After 22nd week of pregnancy, IgM antibodies specific for rubella can also be detected in blood of fetus. Okay. Apart from this, additional tests like immunoblot or IgG avidity measurement, these also can be performed to see whether it is a primary infection or it is a reinfection. It is better if they rule out rubella before pregnancy, so that if at all the mother is not protected, then she can be vaccinated and pregnancy can be healthy. The virus can be detected RT-PCR of viral RNA. Coming to treatment, there's no specific treatment available for rubella. Live attenuated vaccine is usually given along with MMR. In MMR, stands for rubella. Uh, when a person is immune, either by the natural infection or having received rubella vaccine, He might be reinfected when they are exposed, again re-exposed. And this reinfection is usually asymptomatic, and it is detectable only by the serological means, by serological test. Viremia does not occur mostly. That was about rubella. Erythema infectiosum, which is also known as fifth childhood disease. Erythema infectiosum, it is caused by parvovirus B19, and it is very common worldwide and mainly seen among children. Transmission is via respiratory droplets. It can also occur by contaminated hands and infected blood products. After the appearance of rash in this infection, after rash appears, patient is not infectious. Remember this. You must remember appearance of rash and how long the patient is infectious. This is very important in this viral infections. This virus is a non-enveloped single-stranded DNA virus, and it reproduces in mitotically highly active cells like erythroblast. Yeah, they are highly active, uh, mitotically active. So these kind of the virus prefers these kind of cells. In this process, the erythroblast totally they perish because this virus is cytolytic for them. It kills those cells. Okay. And it definitely, when it is cytolytic, it definitely interrupts the erythropoiesis, the process of it. The viral receptor, which is a P blood group substance, which is found on the erythroblast, it is also found, apart from erythroblast, it is also found on endothelial cells, megakaryocytes, fetal liver cells, cardiac muscle, and placental cells. Okay, so these are the cells which carry the specific viral receptors. Now here the virus, it replicates in the nasopharynx, then it spreads by viremia to the bone marrow and to the other parts wherever the viral receptors are available. Talking about pathogenesis of this virus, it establishes viremia and can cross the placenta. Here antibody, presence of antibody is very important, and this virus causes biphasic disease. Two phases you can see in this disease. That is, initial phase, it is related to viremia, which is flu like symptoms, and also patient has this viral shedding. This is initial phase, followed by the immune response. The later phase is immune response phase. Here what happens, the circulating immune complexes uh, of antibodies and virions, they do not fix complement. Okay, so the immune response occurs. This is the second phase, and as a result the rash appears, which is typical maculopapular rash, arthralgia, and arthritis. Second viremia means the second phase of viremia. Infection starts. There are two phases. First phase, second phase. Viremia is like, infection is called as viremia, isn't it? So the initial phase is related to viremia, means flu-like symptoms and viral shedding. In any viral infection, you will see this flu-like symptoms, isn't it? So that is known as viremia. So initial phase, there is initial phase and there is later phase. You got it? Secondary viremia means second phase of the disease. Okay. How does it manifest clinically? The prodrome, it lasts for 7 to 10 days around, yeah. And then in this phase, patient is highly contagious. There might be symptoms, like fever, non-specific symptoms like sore throat, any viral infection you see these symptoms, chills, malaise, or there might be no symptoms at all. It can present in either way, and it is followed by a rash on cheeks. The typical characteristic rash of this infection is like a slapped cheek. When somebody slaps on the cheek, how our cheek turns red. I will show you a picture. So this typical rash on cheeks is like that. Let me show you the picture of it here. This is known as a slapped cheek appearance, redness on the cheek, and then followed by a rash all over the body. Okay, rash on the cheek which has been appears as if it is slapped, and then it spreads to arms and legs and then subsides around over 1 to 2 weeks. The mother who is seronegative, it increases the risk for fetal death. How do you diagnose it? As I've told you before, for all these infections, most important is clinical diagnosis, how the patient manifested and his history, everything. It is completely based on clinical diagnosis. Coming to the laboratory diagnosis, it is by detection of IgM or viral DNA. And apart from that, PCR also can PCR, definitely it's a very good sensitive method for detecting the virus, and there's no vaccine or no specific treatment, any antiviral treatment available for this infection. Only you can treat the patient symptomatically, however they present. Talking about erythema subitum, which is also known as roseola. Exanthema subitum, it is the most common exanthem in young children, like infants and young children. The causative agent is human herpes virus 6 and sometimes human herpes virus 7. These are transmitted by contaminated saliva and also by sometimes by blood products, or even in the stem cell transplants or organ transplants, this can be transmitted. And here the virus replicates in the salivary gland of the patient. Then this virus, they establish a latent infection in T cells and monocytes, and also it may replicate on the activation of these cells. And very importantly, in the immunosuppressive and lymphoproliferative disorders, the virus uh, is likely to activate. They cause many infections in these patients. Clinical manifestations, here the incubation period is 5 to 15 days, and suddenly the child develops high fever, which lasts for around 3 to 5 days. And when the fever subsides, this maculopapular exanthem appears on the neck. It starts from the neck and trunk and begins to disappear within few hours. It is for a very short time. It might be the cause of rash. It is due to the presence of infected T cells or the activation of delayed type hypersensitivity T cells in the skin. It is the most common cause of febrile seizures in childhood, and it might also cause mononucleosis like illness. It's like a flu like illness. Diagnosis is again based on the clinical presentation. Primary infection by IgM or fourfold rise in IgG is detected in these patients. And whether it is primary infection or it is a reinfection or a reactivation, to differentiate this, we can go for IgG avidity. Okay, and treatment, same thing, antipyretics, and if there are any seizures, then we give anticonvulsants. Talking about varicella zoster virus, it is also a member of herpes Which one, dear? Which second point? Can you specify? A diagnosis slide you're talking about? Uh, the detection of primary infection. How do you detect in the patients? Is by detection of IgM. Okay, IgM antibodies. If you detect IgM, then it is primary infection. If IgG is detected, fourfold increase in the normal levels of IgG, then it is a chronic or a reactivation, you can say. Okay, this is how we diagnose the infection. Either you detect IgM or a fourfold increase in IgG. This is how we detect primary infection. And to differentiate it from the reactivation, sometimes the infection is reactivated, isn't it? To differentiate this, we go for IgG avidity test. Now, talking about varicella zoster virus, it is one of the most contagious viruses we see, and it causes chickenpox. I'm sure you all have an idea about chickenpox, how it occurs. And apart from chickenpox, reactivation of this virus in the later life, it can lead to herpes zoster or shingles. This is very commonly seen. Characteristic features of this virus are what it does. It has a ability to establish latent infections of neurons later in life. In childhood, if a person is getting chickenpox, later, after so many years, that virus can be reactivated to cause this herpes zoster. Okay, and it has a characteristic feature. It occurs in the dermatome, the area of the skin supplied by that particular nerve. Okay, you will see the lesions in that dermatome only. And the cell mediated immunity is definitely important in controlling this infection. The lesions are like blisters. I'm sure you know what are blisters, isn't it? Those typical lesions are like blisters. The spread is by respiratory route, and then by viremia to form skin lesions over the entire body. It covers the entire body, and it spreads very rapidly in pediatric age group. Incubation period is around 14 days. You will not see any lesion at the site of entry. That is, enters through the respiratory tract. There you will not see any lesion, but whole of the body will be covered with these typical lesions of varicella zoster. Excuse me. Skin lesions, they are filled with virus particles. So if there is any direct contact with the skin lesions, then the transmission is possible with it. And you cannot isolate the virus from respiratory tract, only from these lesions. The virus infects T cells, and these cells, they transfer virus to skin epithelial cells. Okay, the virus, it escapes somehow the interferon alpha, and vesicles are produced in the skin. The lesions look like fluid filled vesicles, and then they appear first on the trunk, then on the face, on the scalp, and then less commonly followed by legs and arms. It is known as basically centripetal distribution. How does these lesions appear? They are like crops. All the stages of lesions you can see at the same times. Cluster of lesions appear. So like crops, they grow for several days. Then they develop into pustules, and then they break down, scab over, and heal. And this is one of the 5 classic childhood xanthems. This zoster virus, varicella zoster virus, it can form syncytia. This is the cytopathogenic effect we spoke before about. So the CPE shown by this virus is syncytia formation. like the all the cells get clubbed and it forms a giant cell, and they spread directly from cell to cell. A disseminated life-threatening disease can occur in immunocompromised people. This is how the chickenpox rash looks like. You can see all kind of macule, papule, vesicle, blister here, and this is ulcerative lesion. These are typical of chickenpox. This is shingles. Shingles is nothing but reactivation in the later life, and it will affect uh, that particular dermatome only, the skin supplied by that particular nerve. Diagnosis, again, it is clinical, but there are but there are molecular tests available which detects viral DNA, and treatment is, it is a mild illness. Within few days, the rash, the lesions disappear. So we just give symptomatic treatment to the children. If it is in adults, which if it is very serious, then in those kind of cases we give acyclovir. A live attenuated vaccine is also available for this. Here we end the lecture. If you want me to repeat something or if you have any doubts, you can ask.